Hello, everyone, and good evening, and welcome. It's great to have you all with us today. Today's session focuses on one of the most common endocrine diseases we see in practice, Cushing's disease. Cushing's is one of those conditions that often looks simple on paper, but in real clinical life, it can be challenging to diagnose, monitor, and manage. Small details really do make a big difference, both for patients and for the success of treatment. This webinar is a part of our ongoing educational series with Dechra, designed to help veterinarians build stronger practical skills and more confidence in managing chronic and endocrine disease. Before we begin, today's session is interactive. During the webinar, we will be asking you some questions using Slido. You can either scan the QR code on the screen or use the Slido link, which we have pinned for you in the chat. If you have any questions at any time, please feel free to type them in the chat. We will go through all the questions and answer them at the end of the session. Now it's a pleasure to introduce our speaker today, Dr. Ceri, Technical Manager at Dechra Pharmaceuticals. Dr. Ceri graduated from the University of Liverpool in 2011. She spent 8 years working in primary care companion animal clinic across the UK and New Zealand, which gives her a very practical clinic-first approach to education. Her professional interests include internal medicine, endocrinology, fly medicine, and clinic nutrition, making her a perfect fit for today's topic. Please joining me to welcoming Dr. Ceri.
Thank you so much for that introduction, and good afternoon and welcome everybody. Thank you so much for joining today. My name is Ceri. I'm one of the technical vets at Dechra. So I am absolutely delighted to be here supporting the veterinary group and talking about one of my all-time favorite topics of discussion, which is canine Cushing syndrome. So before I start, what I would like to do is ask you to visualize the last case of Cushing's or suspected Cushing's case that you saw that gave you a bit of a headache. So what was it about this case that left you scratching your head? Hold that thought in your mind as we go throughout this webinar. When I joined Dechra back in 2019, I had quite a few sort of aha moments just on Cushing's alone. And one of the most rewarding parts of my job, and one of the best things I hear when helping vets with any cases of Cushing's, is that point where everything just sort of clicks into place and they go, oh, that makes sense. So I wanted to share with you today 3 of those moments today that you can use tomorrow. And as Agnes said, I want to keep this webinar as engaging as possible. So please do join in by scanning the Slido QR code that's on the screen now. You can also go to slido.com, which I believe is also in the chat, and enter the code that's on the screen here. So you'll probably need your mobile phone, or if you're on a laptop, you can join on slido.com. But all answers will be completely anonymous. So please don't hesitate to get involved. It will just make the webinar a little bit more fun, a little bit more engaging. Okay, so let's try this out. I want you to think about the last case of Cushing's that you suspected. And this question is something we get asked quite a lot. What is the most important test to use to diagnose Cushing's? Okay, so in your mind, what is the most important test you can use to diagnose Cushing's? I've put some examples on the screen here, so you can choose from the low-dose dexamethasone suppression test, the ACTH stimulation test. Some of you might use urine cortisol creatinine ratio. You might just use biochemistry, clinical signs, or something completely different. If you have selected other, I would be really intrigued for you to put that in the chat. I think we can all learn from each other. I'm always interested to hear what other people are doing and using. So yeah, if you do use something that I've not listed, please pop that in the chat. I think that would be really interesting. Okay, I see someone's broken the mold and gone for ACTH stimulation test. Okay, I'm going to move on to monitoring. So in your mind, what test would you think is most important for monitoring Cushing's? So again, is it the ACTH stimulation test, pre-pill cortisol, clinical signs, or other? Okay, we've got a good split there. Thank you so much for getting involved. And they are slightly trick questions, I have to say. So when we discuss cases with vets, often the first thing vets lead with are the results of either endocrine testing or monitoring tests before giving us any information about the patient, the signalement, or clinical signs. Actually, the most important factor in both these scenarios is the patient right in front of you. And that leads me really nicely onto our first theme of today, and that is that clinical signs are king. And this applies to both diagnosis and monitoring of Cushing's. So diagnosis of Cushing's, sorry, and monitoring of dogs on trilostane treatment in particular. So let's start with diagnosis. Now, when it comes to diagnosis, we want to be led by the signalment and clinical signs. So we want to really move away from kind of fishing for Cushing's on some abnormalities on routine blood work, instead of actually shifting the bulk of our attention to that patient themselves. So again, I want you to imagine you have a Cushingoid dog in front of you. I want you to picture that. How old are they? What breed are they? Is there anything that you notice by looking at them that makes you think Cushing's before the owner has even started to tell you their concerns? Most Cushingoid dogs are kind of middle-aged to older dogs. There are some breeds that are predisposed, like terrier breeds, so Yorkshire Terriers, Border Terriers, Bichons as well. And when we have all this information, even before we know much more, we can already start to have an idea as to whether Cushing's is likely to be on our differentials list or not. Now, I've mentioned a few kind of predisposed breeds there. I've practiced mostly in the UK. I've done a little stint in New Zealand, like Ahmed said. And I would be really interested actually to understand what the most common breeds you see with Cushing's in your clinics. So I've never worked as a vet in the UAE. I would be really interested to see if there's overlap. Is it the same? Or are there some differences in terms of the type of dogs that you see with Cushing's? I'll give you a little bit of time to think about this one. Yeah, Yorkies. Bless them, they definitely seem to be very predisposed to Cushing's. Poodles, interesting. Yeah, Frenchies. Interesting. Thank you for answering that. That was purely for my own benefit, to be honest. Boxers, yeah. So when I ask you to imagine a dog with Cushing's, some of you may have imagined a dog that looks a bit like this. So let's make this Yorkshire Terrier very, very Cushingoid, just to help us demonstrate the clinical signs that might increase our likelihood or the suspicion of the dog having Cushing's. So we would probably expect to see some changes like alopecia, particularly that kind of flank alopecia, that non-pruritic alopecia. Quite often they're PUPD, so they're drinking more, urinating more, polyphagia as well. So quite often, these are all the types of things that the owner notices most at home as well. So they'll say things like they're always begging for food, they're not able to hold the urine overnight, they're having accidents, they're always thirsty. Quite often they're panting a lot as well, and that could be quite noticeable to the owner. And they quite often have sort of poor exercise intolerance and become very sluggish, less interested to go on their walks. These are all aspects that really have a big impact on the dog and the owner. Typically, they'll have a bit of a pot belly and things like that as well, due to the muscle kind of wasting in the abdomen, but also enlarged liver can often happen with Cushing's. There are, of course, a myriad of other clinical signs, but I would think we can all agree that these are the sort of main ones or the most typical. So leading on from that, I'm going to bring you right back to this morning, assuming you were in work this morning, back to your morning consultation list. So imagine this was your morning consultation list. Apologies, I should have updated the date on this slide. But please have a little look at each of these animals. And for each one, consider their signalment and what they're presenting for. And then I'm going to ask you to think about each of them in terms of whether Cushing's we think is likely or unlikely in that patient. So, for example, if we take Fred, he's booked in for a dental admit. Probably unlikely that he has Cushing's, although he does fit some of the signalment. Snickers, he's a young dog. He's urinating in his bed, but 2.5-year-old is very unlikely to have Cushing's. Similarly with Tilly, the boxer here, she is drinking lots. She's a boxer, but she's still young. She's vomiting. We don't see that very often with Cushing's, and she's got some discharge from her back end. I'm going to say Cushing's is pretty unlikely there. Whereas if we take Minnie and Milo, they look like they could have some clinical signs. They're the right signalment. Yeah, pretty likely that Cushing's is on my differential list at least. I'm not saying it's the most likely. There can be plenty of other things that are on the differential list, but we can already start to have a little idea as to what might be there or the likelihood of Cushing's. And the reason I'm going on about that is because a Cushing's diagnosis is really all about gathering enough evidence to perform specific adrenal tests. So Dechra have worked alongside the Royal Veterinary College in London to integrate basically a validated clinical prediction algorithm, which supports decision making and increase your confidence in pursuing diagnostic testing. And this model has also subsequently been tested on alternative data sets in other countries and other universities. So that kind of increases its validity. And essentially, this model is available in a PDF format. I have put the link in the chat as well, and I can also circulate it after the webinar. But it's just a handy little tool. It's literally just a PDF, so you can either print it off or you can fill it in on your computer as well. And it just has a selection of criteria. You score your patient as to, whether they fit the criteria or not. It gives you a total score and then ultimately a percentage likelihood of how likely that dog is to have Cushing's or not. And that can be really helpful in terms of deciding whether or not we want to run a diagnostic test. Quite often they're not that cheap or straightforward. And it can also be really, really helpful if you have an owner that's not quite convinced or is not doesn't really have the buy-in to do diagnostic tests, or they're just not sure whether they want to commit to that. Having a more objective measure can be really helpful to get them alongside. So let's just build on that. So we've used our initial assessment with these cases here to decide if we think each is likely or unlikely to have Cushing's in our own minds. So let's go a step further and actually see, what happens when we enter just this basic level of information into that prediction tool to see how likely it is Cushing's is in each case. So we said Fred was pretty unlikely. The tool agrees. Equally for Snickers, very unlikely to have Cushing's. Minnie and Milo, pretty likely actually that these dogs have Cushing's, based purely on the information on the screen. So as you can see, we can be pretty confident whether a case will have Cushing's even before we have any information from initial testing, from clinical exam, biochemistry, urinalysis, etc. And obviously, in practice, we would build on the level of information we have with more our clinical exam and initial tests. So in any cases where Cushing's is on our differential list, we do initially need to do some kind of basic initial tests because there will be other potential pathologies on your list too. So we need to rule out other differentials. We need to check for comorbidities. These are sort of middle-aged older dogs after all. And we need to check for anything that might make treatment for Cushing's more complicated if we do go on to diagnose it. So we need to start with hematology, biochemistry, and urinalysis. And here, if we're aiming to build our suspicion of Cushing's, with hematology, we're looking for a stress leukogram. With biochemistry, quite often we'll have raised ALKP, and quite often this is relatively like moderate or marked, whereas the ALT is usually more mildly elevated. Quite often we can have increased triglycerides and cholesterol. We tend to get a low total T4 if you're measuring that alongside your biochemistry, and that's because Cushing's is a non-thyroidal illness, suppressing our thyroid hormones. We can sometimes also see a low urea or creatinine or a low normal urea and creatinine, and that's generally because of the diuretic effect of cortisol on the kidneys. And with Cushing's, in our urinalysis, mainly we're looking at the urine specific gravity, and typically in Cushing's, it's quite dilute, so less than 10-20. So if we see any of these, that may increase our suspicion of Cushing's. Obviously, we don't always see every single one. So really, it's all about getting the different pieces of the puzzle together. And like I said, it's really about building enough evidence. So we need to consider the signalment, the clinical signs, and initial test results for every case. And for each case, I'd like you sort of pause and ask yourself, has this case gone over the threshold to justify running a diagnostic test for Cushing's? Are there any findings that make Cushing's less likely? Is there any concurrent disease present that will make this more complicated case to diagnose or treat? And really, only if we have ticked all of these kind of criteria do we have enough evidence to justify pursuing a specific diagnostic test. So let's kind of put that together and let's take a look at Fred as a case example. So Fred is an 8-year-old male neutered Chihuahua. And he's one of these, our first appointment on the consultation list I shared. He's come in for a routine scale and polish. So he's in for his admit appointment. Before his scale and polish, he has pre-anesthetic bloods. And these show quite an elevated ALKP and a mildly elevated ALT. He's also got mild lymphopenia. Those bloods make you a little bit suspicious. You decide to do a urinalysis, and he has dilute urine with a USG of 10-15. So based on this information, would you run a diagnostic test for Cushing's for Fred? So I'll put that question to you. Would you run a test for Cushing's on Fred? Like I said, it's all anonymous. There's not really any right or wrong answers. Okay, well, we're split 50-50. Okay, so actually, no, I wouldn't, or at least no, not yet. So if we look at those criteria for testing for Cushing's, yes, we have typical signalment. Yes, he's got biochemistry and urine changes that are very suggestive of Cushing's. But actually, we've got no idea about his clinical presentation. So we need much more evidence before we can justify doing an endocrine test. If we put that information that we've gathered so far into the prediction tool, we can see actually that the percentage likelihood is still pretty low. It's only 35%. So that can guide our decision making as well. So we need to go back and look at Fred, and we also need to speak to his owner and get a bit more history. Following further history, you speak to the owner, they say, actually, now you mention it, he is always begging for food. And actually, the last couple of months, we've noticed that he's had a few accidents in the night. And when you do a little sort of repeat clinical exam, you notice actually, there's a little bit of alopecia here. So just that information alone from a simple conversation and re-examining the dog, do we have an increased suspicion of Cushing's now? Yes, absolutely. I think you can all agree. And then if we have that new information to the predictor tool, lo and behold, yes, the prediction tool also agrees 88% chance that this dog has Cushing's, or an 88% likelihood. And I think you can all agree now we absolutely have enough information to justify endocrine testing for Fred. And this is also a really good way of convincing the owner to pursue diagnostic tests as well. Let's just briefly look at the Bichon that we had on our consult list, Minnie. She already, just on the information we had from the receptionist, had an 87% chance of or likelihood of having Cushing's. Now, from our consultation and performing some initial tests, actually, we have a bit more information, and we have a bit more evidence, of Cushing. So she's PUPD, she's got pot belly, she's been panting, she's got biochemical changes and urinalysis changes that make us even more suspicious of Cushing's. And actually, when we put that into the prediction tool, her percentage likelihood of having Cushing's increases again to 92%. So do we think Cushing's is still our top differential in Minnie's case? Yes, absolutely. And the prediction tool can be will agree. So as you can see, we can be really quite confident that a case can have Cushing's before we even reach for an endocrine test or even have the conversation about what endocrine test we're going to choose. And I also just want to point out with Minnie's case, even if we have a very, very strong clinical suspicion of Cushing's before doing any testing, we still can't miss that step of doing a routine hematology, biochemistry, and urinalysis. It's really important before we make a diagnosis of Cushing's that we've ruled out concurrent diseases, that we have also ruled out anything that makes Cushing's less likely. The clinical signs of Cushing's can mimic a lot of other diseases. So we need to make sure we're not missing that. And as I mentioned, we need to check for anything that might make treatment for Cushing's a little bit more complicated. So would a negative test result in Minnie's case kind of trump your belief that she has Cushing's? So if you did a test in this patient and you get a negative result, would you believe it? I would urge you to trust the patient, not the test in that case. But we'll come on to diagnostic tests in a second. So before we move on to the next theme, we want to talk about clinical signs and monitoring. Clinical signs are also the most important element of monitoring a patient on treatment, particularly medical treatment like Trilostane. So for patients on treatment with Veteral, I really encourage you all to reach a plan for your patient based on their clinical signs before being attempted to look at their cortisol results. The patient clinical signs are by far your strongest tool for assessing the level of control and also optimizing treatment for your patient. So it can also be very helpful then to have an idea of what clinical signs we expect to improve and when. And it's really helpful to be able to communicate that to the owner so they know what to expect and when. So typically after starting treatment with trilostane, by day 10, you should expect that dog to have responded really well in terms of their polyuria, polydipsia, and polyphagia. They should be dramatically improved, if not resolved. By day 28, you should expect many of the metabolic symptoms to have resolved as well. So things like the panting, exercise intolerance should be greatly improved. And by month 3, any dermatological signs like alopecia, any kind of related pyoderma or anything like that should be massively improved as well. And by month 6, for all intents and purposes, they should look and appear like any other healthy, albeit middle-aged dog. And when I say focus on clinical response, I think it can be really helpful to have in your mind 3 key questions for every monitoring visit you have of the dog with that's on trilostane. So that first one being, is the dog well? And it's really important to start with that one. Any dog that's unwell, whether it's related to trilostane or not, they need to have a sort of more of a cortisol response. They need to have that reserve. So is the dog well? Do they have clinical signs of Cushing's? And have they got better or worse? So it really is that simple. If you can answer all those questions in your monitoring visits, you're 90% of the way there. Now, I know it can also be tricky to get that full clinical picture during a monitoring appointment, especially if you're short on time, which I know the vast majority of you will be in terms of the length of consultation time. It can be understandably quite difficult for an owner to remember all of their pet's symptoms since the previous visit. I can't remember what I did 3 months ago on a Tuesday. So, it's quite difficult to have that at the forefront of their minds. And quite often we can have multiple vets involved in monitoring one case. And that's why we developed 2 validated tools, again, in collaboration with the Royal Veterinary College in London, to basically make this information quickly and objectively accessible. So we developed the Cushing's clinical score, and that is basically made it easier to track those most important clinical signs and to see objectively whether they've got better or worse. And then we also created the quality of life questionnaire. And again, that's been developed to evaluate those changes in both the dog and the owner's quality of life over time. So again, more objective measure to see if that's got better or worse. Like I said, they have been validated, so you can trust in the results you get. And I really would encourage you to utilize these tools. They're available through the veterinary group, and we'll also circulate them after the webinar. But it will really help you to standardize your assessment of patients' clinical signs and help give you an indication of improvements or deterioration. It can also really help owners track themselves, like those signs themselves at home. So they can fill this out at home, or they can fill them out in the waiting room while they're waiting for their appointment. And that should hopefully save you a bit of time during the consultation as well. And it really helps in terms of deciding on what dose adjustments are needed. And this is just the reference for the how these tools were created if you wanted to look them up. Okay, let's have another look at a case example. So this is a 9-year-old male neutered beagle, Bertie. He's been on Veteral just for the last month. So last 28 days, he was started on 30 milligram once a day, and he's come in for his medication review. The owner's really happy. His PUPD and polyphagia has resolved. At his previous check, his Cushing's clinical score has improved since then, and the quality of life score from the questionnaire has also really improved since the last recheck. So let's go through our 3 questions. Is Bertie well? Yes, he is. Does he have clinical signs of Cushing's? Nope, no, he doesn't. Has he become better or worse since the last review? Better. And do you suspect he will need a dose adjustment based on those questions? No, he seems to be doing fine, so that's good. Let's look at conversely at Bo. So Bo is an 11-year-old male neutered Labrador. He's been on Vetrol for about 6 months. So he's been on 30 milligrams twice a day. He's come in for his revisit, and actually the owner said he's starting to urinate at night again. He's begging for food more. And you can see from his Cushing's clinical score, this has worsened since his last visit. And equally, the quality of life questionnaire, that's worsened. He's got a reduced quality of life since the previous check. Is he well? Yes. Does he have clinical signs of Cushing's? Well, yeah, he's urinating at night and he's polyphagic, so yeah. Has he got better or worse since the last review? Well, based on what the owners told me and from the tools we've used, he's got worse, definitely. Do you suspect he'll need a dose adjustment? Quite likely, yes. Now, the reason I've showed you those 2 cases is because we've planned to keep Bertie's Vetrol dose the same and increase Bo's Vetrol dose. However, if we measured their ACTH, post-ACTH cortisol with an ACTH stimulation test, we find actually that their levels were exactly the same. And this just shows how important it is to focus on the clinical picture first and then measure cortisol. So Bertie's history and examination suggests that his dose is correct. So if we use our monitoring flowcharts, he's had significant improvement, and a result of 160 nanomoles per litre for Bertie confirms that we're not concerned about oversuppression, and it gives us a green light to continue with his current dose. If we look at Bo, actually, there's been little improvement. He's got worse, in fact, in terms of his clinical signs. And we suspect a dose increase is needed. And with the monitoring flowchart, cortisol of 160 confirms that actually, yes, there's enough adrenal reserve to increase, but because he's still got clinical signs, that we really should be increasing the dose or the dose frequency. And in fact, Bo was switched to 60 milligrams in the morning and 30 milligrams in the evening. And if we look solely at the cortisol result, we would keep both patients on their current dose. And that would leave Bo with a deteriorated quality of life and with very frustrated owners, most likely. And these suboptimally managed cases are not uncommon because cortisol is often given too much influence over our clinical decision making. And really here, clinical signs are absolutely key in getting the best for your patient. You can see by using our monitoring flowcharts that they encourage you to make that clinical assessment first. It's the first step. And in these cases, will guide you to completely different actions. So we do have flowcharts for both pre-pill cortisol and ACTH stimulation test monitoring. So whichever you use for which, whatever patient you have. Again, these are available through the veterinary group, and we can circulate them as well. We are really excited as well that we have recently collaborated with Ficava, and we've created both a diagnosis and treatment and monitoring guidelines for managing Cushing's. And you can see again in our treatment and monitoring guidelines, the assessment of the clinical picture is the first step and is most important. So I spent the longest on theme 1 because I think it's the most important. Theme 2 really is trust in the low dose Dechra suppression test. Now, firstly, I do want to call out that there is absolutely no perfect test for diagnosing Cushing's, which is why it's so important to gather as much evidence as possible from the history, the clinical signs, and initial tests using the tools that we've just discussed. Also, the low-dose dexamethasone suppression test can get a bit of a bad reputation as an untrustworthy tool for helping you make a definitive diagnosis. I was exactly the same when I first graduated. But today I'm going to show you how, in fact, you can trust the low-dose dex suppression test, and hopefully it will change how you think about and approach your cases. I know from the previous question that there's quite a few of you that are using the low-dose dex already, so I won't dwell on it too much. So any test is only as good as what you put in, and that is for any test. And it's really important to always remember that. If you put rubbish information in, you will get rubbish out. So before reaching for any endocrine test, it's important to consider what is the likelihood of the patient having Cushing's, which hopefully we've just got really good at. We also need to use clinical signs and initial findings to select the most appropriate cases to test. And in most cases, you can sort of anticipate the result before testing. So think of a case where you've run an ACTH stimulation test and you've been surprised by the result. So you're testing for Cushing's, you're suspicious of Cushing's, but your ACTH stimulation tests come back negative for Cushing's. What would you do next? Most people then reach for a low-dose dex suppression test. And what that really tells me is you were really confident that you had a patient with Cushing's in front of you in the first place. So cut out the middleman and use the low-dose dex suppression test first, which is less likely to miss a true Cushingoid patient. So I'm not going to put everyone off here by giving you a statistics lesson, but I'm going to have a not too statsy interlude. So the most important thing when considering how useful or trustworthy an endocrine test is, it's the prevalence of the disease in the population we are testing. Basically, how likely is it that the patient I'm testing has Cushing's? So we're going to look at how the ACTH stimulation test and the low-dose dex suppression test perform in the scenario where Cushing's is likely versus a scenario where Cushing's is unlikely. So here we have a 1-year-old duck tolling retriever. He has no clinical signs of Cushing's, no PUPD, no alopecia, no changes on bloods, normal urine. And when we use the prediction tool, it's got a 5% chance of having Cushing's. So in a second, I'm just going to add on some information about negative and positive predictive values. Now, a positive predictive value, just as a reminder, is the likelihood that a patient with a positive result truly has Cushing's. The negative predictive value is the likelihood that a patient with a negative result truly doesn't have Cushing's. So in a population where Cushing's is not likely, both the ACTH stim test and the low-dose dex perform very well in identifying a true negative. However, where Cushing's is not likely, you can't have any real confidence in a positive result with either test. So even though the ACTH stim test comes out on top, I would not like to put my chances on a 28% likelihood that the positive result is really that of a Cushingoid dog. So where the likelihood of Cushing's is low, we can trust a negative result. So we use it as a rule out test potentially, but we can't trust our positive results. Now let's have a look at a case that is likely to have Cushing's. So where the prevalence of Cushing's is a bit more relatable to the population of patients that we're actually going to be testing. Hopefully nobody's going to be doing an endocrine test in a dog that has 5% likelihood of having Cushing's. So here we've got 80% likelihood of having Cushing's. We've just seen how achievable getting to that level of suspicion is. And we can be a little bit more critical about the patient being tested. So testing those where we've built a case to be suspicious of Cushing's, you'll see that positive and negative predictive values are very different from the previous scenario. So where Cushing's is likely, positive predictive values between the two tests are very similar and they're quite good, and we can be relatively confident in a positive result for both tests. Yay, confidently making a diagnosis of Cushing's with either test. So what's the problem? Why can't we continue to use an ACTH stimulation test as the go-to? The problem lies with the negative predictive value. So it's far better with the low-dose Dex compared to the ACTH stimulation test. We're far less likely to miss a Cushing's diagnosis. So really, if we run the ACTH stimulation test and we have a negative result, we'd probably be better off flipping a coin as to whether that dog actually is negative or whether they secretly have Cushing's. And I think this helps to demonstrate that worries about the low-dose Dex giving a false positive shouldn't be too much of a concern, provided that we're testing the right patients. So we should only ever be testing patients where we have a strong suspicion of the disease. Cushing's isn't life-threatening. If we have sort of moderate suspicion, we're not quite convinced, we can wait a bit more time to see if any more clinical signs arise, or we can go digging for a bit more information. We can go back to the owner and try and get a bit more history. It's really crucial that we are quite strongly suspicious before we do the test. And although there's no perfect test, we are quite fortunate that some groups of endocrinologists have created consensus statements and guidelines that can help guide our decisions basically as well. And both the ACVIM consensus statement and the AHA guidelines suggest the low-dose Dex suppression test as the preferred first-line diagnostic test for Cushing's. Also, and these are the new, relatively new guidelines for diagnosing Cushing's that we did with Pacava, again, advocate for the low-dose Dex suppression test being the initial screening test of choice. The one caveat to this is where we suspect iatrogenic Cushing's, they will have a very different history. And in those cases, the ACTH stimulation test would be the gold standard. Now, our final theme of today is dose with purpose. So here I'm talking about how we approach using Veterinary, and importantly, how we approach dose adjustments and how we optimize clinical control of Cushing's. So we've already covered how to assess whether we need a dose adjustment or not, leaning on those clinical signs, using cortisol result just to guide us. But how much do we adjust the dose by, and when is it necessary? So before I go into that, I just want to go really back to basics. Why do we treat Cushing's in the first place? Like I said, it's not a life-threatening disease after all. So I'm curious, why do you treat Cushing's? When you have a suspected or diagnosed case of Cushing's, what do you say to pet owners when you recommend treatment? That's a lovely first answer. Anyone else want to contribute? Yeah. And I couldn't agree more. And it sounds obvious. Of course, we want to improve their quality of life. But I think it's really important to keep that in the back of our minds when we are treating Cushing's. So yes, we want to improve their quality of life. And we do that through improving their clinical signs. Obviously, that is going to make a positive impact on their quality of life. We also want to prevent secondary complications as well. So we can get certain complications like diabetes, for example, is more common in dogs with Cushing's, urinary tract infections, hypertension, potentially pancreatitis, various things that have some association or link with Cushing's. We want to avoid those as well. I'm going to obviously focus on medical management with Veterinary. So Veterinary from Dechra comes in 3 different strengths of trilostane. We do now have chewable tablets available in Europe, and we are working as best we can to make those available in as many countries as possible. And the licensed starting dose for Veterinary is approximately 2 mg per kg once a day. And it's important to note that it's for really managing cortisol production. So it's not going to treat the underlying tumor. So it's really important, therefore, that dogs have long-term treatment to control the clinical signs of Cushing's and therefore will require long-term and regular monitoring. And in your experience, what does a dog receiving Vetral look like? And really, if we are going by what we have just said, that we want to optimize the quality of life, then we should be aiming for our patients to look, behave, and feel like any other normally or well dog. Okay, so that's what our aim should be. And it's helpful and important to know how trilostane works as well. So trilostane reversibly inhibits the enzyme 3-beta hydroxysteroid dehydrogenase. And like I said, that kind of basically reduces production of cortisol, which means that the dose can be titrated, sorry, to effect. As I mentioned, it doesn't treat the underlying tumor. All we're doing here is controlling clinical signs to improve quality of life. And as I mentioned, because of that, they do require long-term treatment, and they will require regular and long-term monitoring. If surgery is an option and is becoming more and more available, then that definitely should be considered and it should be given as an option to the owner. But where it's not an option, trilostane offers a really useful tool to make a real difference to pet and owner quality of life. And the reason I say dose with purpose is because the pharmacokinetics of trilostane and the response of cortisol to trilostane are quite unpredictable. They don't change linearly with dose changes. Also, as per the data sheet, you don't necessarily need a precise starting dose. So the starting dose is approximately 2 mg per kg once a day based on available capsule sizes. So if a patient weighs 17 kilograms, we start on 30 milligram once a day. If they weigh 13 kilograms, we start on 30 milligrams once a day. In general as well, we recommend dose increases of 25 to 50%. I know that's quite a wide range, but we have to be quite pragmatic and take into account how well the dog's doing clinically, what any limitations might be from the owner, etc., etc. But the point being, if we are too incremental with dose adjustments and we're making small dose changes, owners and yourselves could become quite frustrated if they're not seeing the clinical improvement that they want. And it can prolong the period of poorer quality of life while we're failing to optimize control of Cushing's clinical signs in that patient. Remember that Vetral reduces cortisol production via reversible inhibition of the enzyme involved in cortisol synthesis. So if we give too much and send the cortisol too low, these cases usually respond quite rapidly to stopping Vetral and reintroducing at a lower dose. So let's look at Sky. So Sky was a real case, came in as an inquiry. She'd been on treatment for some time. She still had persistent clinical signs of Cushing's. So her cortisol is elevated, as we would have anticipated based on her presentation and clinical signs. And both of these information support that she needs a dose increase. And in this case, Sky's dose was increased to 100 milligrams twice a day. Unsurprisingly, she remained symptomatic, so it didn't really make any real clinical difference. And it can be easy to be worried about increasing Vetral and using quite small capsule to add in a change in the dose. But realistically, it's very unlikely that a 10% dose increase will make any clinical significant difference to the to the patient, sorry. And let's not forget, with trilostane, there's quite a heavy burden in terms of monitoring. There's a financial burden involved with that as well. Every time we do a monitoring test, we're risking the owner's compliance with the medication. And there's a huge risk that when they become frustrated and they're not seeing a response, that they may stop treatment. So I just want to ask you as well, before we go through the final couple of slides, what is your biggest concern when increasing the Veteral dose? So if you have a patient, you think you need to have a dose increase, what are there any concerns you would have in doing so? And like I said, there's absolutely no right or wrong comment. Everything's anonymous. And it's all very useful information, I think, to share. Yeah, so the dog can feel unwell if cortisol levels drop too quickly. Absolutely. And I'll touch on that in a second because that is an absolutely important one. Someone's just typing, so I'll let them. Other conditions might show. Yep. Yep. Yeah, and those are all absolutely valid concerns. So let's just go through some of those. First of all, it's not uncommon to be worried about increasing Veteral doses too much, or particularly if you're already at like a relatively high dose, you can be worried about going beyond a certain milligram per kilogram. And I am by no means going to sit here and say that complications don't arise because trilostane is an extremely useful tool in managing Cushing's, but it can have side effects and it does require lifelong treatment and close monitoring because of that. So it's why we put so much emphasis on having a confident diagnosis of Cushing's before we even start treatment. Now, often people's main concern is adrenal oversuppression. So here we have cortisol and potentially aldosterone production suppressed below sort of normal levels. So we can get things like poor appetite, lethargy, gastrointestinal signs, and these dogs will have a low post-ACTH cortisol and potentially abnormal electrolytes as well. This is very uncommon, and Veteral is titratable and reversible. So it's extremely unlikely that 1 or 2 doses of Veteral will result in an Addisonian crisis. The most common and earliest complications are mild, so like lethargy, inappetence, etc. And if we do continue with an inappropriately high dose, ignoring any signs of oversuppression, like inappetence or weakness or GI signs, then that obviously can result in an unwell patient. So you do need to work with your owners to monitor clinical signs and patient wellness after starting Veteral and after any dose changes. But remember, the adverse effects of Veteral are often mild and self-limiting. We can also get cortisol withdrawal syndrome. So that is that relative deficiency in cortisol. So these dogs tend to have a normal cortisol level, but because it's less than it was prior to treatment, they're struggling to cope with that sudden drop. And interestingly, they present very similarly to an oversuppressed dog, but maybe slightly less severe, so not quite so dramatic clinical signs. And it's usually most common sort of a few weeks after starting treatment. Thirdly, we can have unmasking steroid responsive disease. So when we lower a dog's cortisol level to like a more normal range, this can unmask underlying inflammatory diseases. So things like IBD or arthritis or atopic dermatitis. And sometimes reviewing the history can kind of determine whether or not that is likely to occur. And then finally, we can get other causes unrelated to Veteral as well. So don't forget these are middle-aged to older dogs. So concurrent diseases can occur. So it's important that we rule these out as well. Ultimately, if a patient on Veteral does present unwell, we just need to pause Veteral while we run some other tests. So we need to do a biochemistry, electrolyte, and ACTH stimulation test to assess what the adrenal reserve is, make sure we're not missing any other sort of concurrent morbidities, provide supportive treatment if needed. Oops, sorry. And ultimately, if we do have oversuppression or cortisol withdrawal syndrome, then a simple treatment break until the animal is clinically well, they have clinical signs of Cushing's, and they have an elevated post-cortisol ACTH stimulation test, then we can restart at a reduced dose. And we do have all these tools here to help monitoring dogs on Veterinary as straightforward as possible to minimize any of those risks. And there is information in our monitoring flowcharts as well on what to do if we are in those unlikely situations where we have an unwell dog on Veterinary. So thank you so much for joining today to let me talk about my favorite topic and also share my 3 most useful sort of aha moments, as I like to call them. I hope that remembering clinical signs are king will give you more confidence in diagnosing and monitoring your Cushing's cases. I really challenge you, if you're not already, to use the low-dose DEX suppression test for the next case where you're suspicious of Cushing's, having built in that level of suspicion before reaching for the endocrine test. And remember that, dose with purpose. Remember what we're trying to achieve with Veterinary. Our end goal is to get that quality of life back to normal levels for the dog. And micro-adjusting the dose can potentially lead to more expense, more frustration, and could lead to that dog stopping treatment or the owner stopping treatment. So finally, I just want to ask you what your take-home messages are from this webinar. So what are your key learnings? They might be hopefully the same as what I intended, or it could be something completely different. But if you could share that, it would be really, really appreciated. Yeah, monitoring clinical signs, absolutely. And I think if I had to choose one of those sort of themes, it would absolutely be that one. Yeah, dogs with Cushing's are not a walking cortisol result. There's a dog attached. Yeah, completely agree. And then finally, and this won't get displayed on the screen. This is purely just for myself and my colleagues. How likely are you to recommend this webinar to a colleague? Your input to this could be really helpful to us in developing educational materials or training for future and just making sure that any of our content is as relevant as possible as it could be to you. Thank you, and thank you very much to the veterinary group for inviting me to speak. It's an absolute pleasure to work with you guys, and I have put Dr. Ahmed's contact details on the screen here. Should you want any sort of further support with any of your Cushing's cases, and as I mentioned, we will be, well, the veterinary group will be circulating all of the materials I mentioned in the webinar shortly afterwards. Thank you. And I'd be very happy to take any questions.
Yeah, thank you, Dr. Ceri. And now we will open the door for all your questions. Just typing your questions on the chat. But I have personal questions about the
Absolutely.
chewable tablets. What is the difference between the chewable tablets and the capsules? And the chewable tablets can be divided or not? Because here in UAE, the clinic, they are struggling to get the lower dose 5 milligram.
Yeah, good question. So yeah, the chewable tablets we are very excited about. So they are divisible. They're actually doubly divisible. So you can split them into 4. They are currently available in 20, 30, and 60 milligrams. That is in Europe at the moment, and they're flavored. So that will help with compliance. And the way that they are designed is essentially what we call like a smart tab kind of design. So they're very, very easy to split. So when you just push down on them and they will split into 4 equal portions. So there's just limits any kind of dosing error when you're splitting tablets. So yeah, we're very excited about them. Hopefully it will also mean that You have so much more dose flexibility. I know I mentioned about sort of making kind of slightly bolder dose increases, but of course, if you have smaller dogs or you have some dogs that do require smaller dose adjustments, then you just have those additional options to you as well. I think somebody's asked, is it hypoallergenic? So we use a hydrolyzed chicken protein as a flavoring in it, as well as a yeast kind of meat flavoring, which is based on yeast. So we haven't done any tests on allergenicity, but we wouldn't, yeah, they should be relatively allergen free.
Okay. Is there any more questions? Okay, I think that's it.
Lovely.
Okay,
I can
lovely.
talk
Yeah,
about Cushing's all day, so any other questions I'd be happy to take at another time.
yeah, of course. And I'm here to answer your question individually. If you need, you can contact me directly. And yes, this meeting it's recorded. We will send you the materials within 2 working days with your certificate. That's it. And yeah, of course, there is 2 winners. We will make the draw and we will announce the winners in 2 days. Thank you for your time and thank you for your joining. Have a nice night.
Thanks, everyone. Bye.
Bye.